I look forward to hearing from Professor Stigma Krishna Shastri. So for those of you who are joining us for the first time today, iChords is a community of practice that centers around the social and behavioral sciences in the field of neglected tropical diseases. And its purpose is to bring people in this field together to learn and collaborate with each other. And one way that we do this is through our knowledge exchange cafes, which help us hear from experts in the field and to hold a discussion on the concepts that are shared and learned. And so during this session, please feel free to put any comments or questions you have in the chat, and we can address them during the discussion portion of the session, which takes place after our speaker's presentation. And so during our session today, we will review how one's community can be used to implement the essential package of care in morbidity management and disability prevention for lymphatic filariasis. And our speaker today is Professor Stigma Krishna Shastri. She is the director of the Filariasis Research Center, the WHO Collaborating Center for LF MMDP. And Professor Stigma Krishna Shastri completed her medical training at the Government Medical College in India. She is now a professor of medicine in the Government TD Medical College in India and has been actively involved in research on lymphatic filariasis for over 3 decades with the WHO TDR. She has a specific interest in morbidity management and disability prevention in LF endemic countries. And the discussion portion will be moderated by Caitlin Worrell, who is an epidemiologist and has recently joined the Neglected Tropical Disease Division within the U.S. Agency for International Development as the LF Technical Advisor. She's detailed to USAID from U.S. Centers for Disease Control and Prevention. She is particularly passionate about ensuring that all persons who are already impacted by the debilitating consequences of lymphatic filariasis have access to high quality care and treatment. So thank you to you both for taking the time out of your day to join us today and to share your knowledge and expertise with our attendees. And so I'll pass it over to you now, Professor Krishna Shastri, for your session. Do you need any help, Suma?
Yeah. Can you see the slides?
It's in just the PowerPoint app again.
Oh, so that's before.
So if you go to the top left, play from start. That's it.
Yeah. Okay. Good morning, good evening, wherever you are. Today, we are going to hear about lymphatic filariasis, morbidity management, disability prevention, what the community could do to enhance the program. Now, we all know that the lymphatic filariasis is one of the neglected tropical disease which comes under Hermans. And NDDs, there are more than 1.7 billion people affected with NDDs. Now, we know that the global program to eliminate lymphatic filariasis was launched in following the WHO Assembly 50.29, and there are 2 components: stop the spread, that is interrupt transmission by mass drug administration, and reduce suffering and improve quality of life of those people affected with or suffering with lymphatic filariasis disease. That is the morbidity management and disability prevention. Now, we know that in MDA is going on very well, and in MDA, there are a lot of involvement from the community. And I would like to say that MDA is one of the very good, well done public health program. And there are volunteers, community leaders, and community workers, and others also. And volunteers, we know that there is an important part of awareness creation. And when there is awareness creation, there is the coverage of the mass drug administration has been increased. And the community leaders and the healthcare workers, they knew more about the disease and the infection, as well as the health literacy. Why should they take the medicine? What are the benefits? How that is going to improve the community? And also about because it is a vector-borne disease, about the vector also. And the community workers were the community drug distributors. And always we have to consider about the community drug distributors, because the main part of the success goes to them. So similarly, whether the community involvement can enhance the morbidity management and disability prevention is the question here. Okay, so I think here we have talked about the awareness creation first, or the transmission of knowledge. So briefly, I will tell about what is morbidity management, disability prevention, as well as essential package of care. And everybody knows that lymphatic filariasis is a mosquito-transmitted disease, and there are 3 species of parasite: W. bancrofti, Brugia malai, and Brugia timori. In the spectrum of infection and disease, there are 3: asymptomatic microfilariae, then chronic manifestations like lymphedema and hydrocele, then acute, most important acute manifestation, adenolymphangitis, or the acute attacks. Now, what is this asymptomatic microfilariae? This is very important to know in the program of elimination of LF. Once the mosquito deposit the L3 larvae on the body of the person, it goes, sorry. Am I audible?
We can hear you, Suma. It's just if
Yes,
everyone could just
madam,
keep muted during the session, that would be great. Thank you. Sorry, go ahead, Suma.
Okay. So when the L3 larvae is deposited on the skin, it goes to the lymphatics, and there it goes into develops into adult worms and produce millions of microfilariae. And these microfilariae are seen in the peripheral blood during night. But these people will not have any symptoms of filariasis or any manifestation, but there will be the basic abnormality, the lymphocyte dilatation in them. So these are the people who will be transmitting the disease through the microfilariae. So the majority of LF infected people are the asymptomatic microfilariae. Now, the chronic manifestations are lymphedema and hydrocele. So I was telling that the larvae goes into the lymphatics, and it gets deposited and grows in the lymphatics to become the adult worms. In the male, the larvae lives mainly in the scrotal area and the inguinal area, and in the female, in the inguinal area and the medial aspect of the thigh, then over the axillary area, epitrochlear area, and very rarely on the breast. So there will be dilatation of because of the adult worm, they dilate the lymphatics. When they dilate the lymphatics, the function gets affected. Normally, it's a defense system which take the unwanted particles from below upwards. So the dysfunction occurs when there is a dilatation, and that will lead on to accumulation of fluid on the leg, mainly over the leg, that and result in lymphedema. Lymphedema can happen both in male and female. It can affect legs, either unilateral or bilateral. It can also affect the upper limb. But the scrotal or breast lymphedema are very rare. And the same thing, the lymph accumulation and the fluid accumulation in the scrotal area will produce the hydrocele in W. bancrofti infection, only in male, So these 2 are the main chronic infections. And the basic pathology is the lymphatic dysfunction. And the important part is that it has been demonstrated even in children of 3 years, because we were really believing earlier that this lymphatic filariasis is a adult disease, but now we have more than sufficient evidence that it's a childhood disease. The infection starts in the children. So we always, in the programs, we should consider or take into consideration the children as well. So the lymphedema, as I have told, it can occur unilaterally or bilaterally. I'm not sure whether it is clear, but this person has bilateral upper limb also have lymphedema. This lady has bilateral lymphedema over the upper limbs. Upper limb lymphedema is more common in females, but and it is not as common as the lower limb lymphedema. And when you are thinking of the program, elimination program also, we should understand that it is not only the physical problem we have with the lymphedema. Lymphedema, because of the difference in sizes of the leg or because of increase in size, they'll have a lot of physical problems, like they will not be able to walk as the other people. They will not be able to use the public transport, getting into a bus and all that will be difficult for them. And they will not get the job, appropriate job, which other people of their age will be getting because of the physical disability. And some people will remove or will not give a job also. And another thing very important is the stigma, because these people have swelling earlier days, because when we didn't know what is the treatment, there was no treatment being given to them. So usually they'll have ulcers, they may be oozing, and they may be foul smelling. So that's a very high rate of stigma used to be there. And also there is exclusion. We had patients who come and tell us that they will not be allowed to come to the front of the house, or it should not be, they will not be allowed to get out of the room when they have guests or other people coming to them. So there was a lot of exclusion and neglect. And this leads on to the mental health issues also. And these people get recurrent episodes of fever or adenolymphangitis, and that result in economic loss also. There'll be out-of-pocket expenditure, and they will not be able to work for those days with fever. So there'll be definitely an economic constraint also is there. So the lymphedema affects in different ways the person affected. Sorry. So most important, I have told about lymphedema. And the most important acute manifestation is acute adenolymphangitis or the ADL attacks. This is gaining very much importance, and it is important to know everything about the acute adenolymphangitis. This is the commonest acute manifestation of lymphatic filariasis. There is acute inflammation of the skin. There will be the enlargement of the lymphocele gland, and this is caused by bacterial infection. Previously, here also it was thought that acute adenolymphangitis is could be due to the molting of the worms or some worm products and all that. But it is by studies, it has been proved beyond doubt that it is due to bacterial infection. So like in any bacterial infection, the person will have high fever, pain, swelling, and nausea, vomiting. Some cases, there'll be altered sensorium, and some people will have incontinence as well. Usually lasts for 5 to 7 days. And some patients can have episodes 2 to 4 episodes per year. So as I said, it is a bacterial infection, and some of the studies have shown that it is most commonly the streptococci and staphylococci, which are the organisms which cause the acute adenolymphangitis, but could be caused by any organism. Depending upon, suppose the person has diabetes, there could be a high-end bacteria, which or severe, highly virulent bacteria could also cause acute adenolymphangitis. So what is the importance of acute adenolymphangitis? One is, as I have just said, the economic loss and the difficulties and the problems. Usually what happens is, we have seen that even when the person has grade 3 lymphedema, they may not seek medical help unless they get a acute adenolymphangitis, because that is the main thing which makes them come to the hospital or a doctor. So when there is a recurrent lymphedema, the edema which occurs in the episodes remains like that when it gets relieved. So when there is a recurrent edema, it hastens the progression of lymphedema, because each time the edema is remaining and the edema gradually increases. And usually what happens is when it is a higher grades of edema, there'll be skin changes and they'll be more prone to get more radial attack, and it becomes a vicious cycle. So in case of lymphedema management, it is very important promptly treat ADL as well as to prevent ADL. So if it is not prevented, the lymphedema is going to advance. So the question is, why do they get the acute adenolymphangitis? Because the patients with lymphedema usually have a lot of skin changes. If you can look at the different pictures, and these are different the grades of lymphedema or stages of lymphedema. This is a young girl. The skin is not much changed here also, but you can see that in this patient there are folds there. So there are thickening of the skin and folds are there. In this person, there is multiple nodules are there. In this, there is deep fold is there, and this is what is called as the and the grade 7, there are a lot of issues. So all these skin changes are there. And so when there is skin change or a break in the skin, because everybody has bacteria in their body or in their skin surface. That's a normal commensal. And this skin surface bacteria enters into the body when there is a break in the skin. Normally, what happens in a normal person without lymphedema, what happens is when these bacteria enters, they will be taken out or removed by the lymphatic system. And this break in the skin is termed as entry lesions, which are any break in the skin that allows bacteria to enter the body. So, and usually it occurs between the toes or in deep skin folds, and through wounds on the surface of the skin, cuts, scrapes, and scratches. And so the entry lesion means any cut over the skin. It could be like a cut here, or this is what is the interdigital candidiasis. This is interdigital candidiasis, which is in the lower limb between the big toe and the first toe. Especially, this is except in dry places where there is more water. This is the commonest entry lesion which used to be seen, especially in the interdigital space. This again is an interdigital candidiasis or fungal infection in the upper limb. And you can see there are a lot of skin is excoriated and there are nodules also. These all will create issues. These all can function as entry lesions. So when there is an entry lesions, as I have told, the bacteria enters into the body, and unlike in normal people, what happens is there will be impaired transport of bacteria to the lymph nodes and reduced ability of the body to fight the infection. So the bacteria will not be removed from the body through lymphatic system. And also there will be a lot of lymph fluid. I was telling that in lymphedema, there is a collection of lymph fluid. And this lymph fluid is a good medium for bacterial growth. And bacteria happily multiply, causing the painful acute attacks. So whenever there is an injury or there is a cut or even a thorn prick or nail infection or bacteria, the fungal infections per se will not produce acute adenolymphangitis. What happens is when there is fungal infection, people tend to scratch because it will cause severe itching. So when they scratch, the skin gets broken. That is how the bacteria enters and produces the acute adenolymphangitis. So this is very important to promptly treat and also to prevent acute adenolymphangitis. Now, about lymphedema and hydrocele, because I was more concentrating on lymphedema. Hydrocele, usually it is the collection of fluid in the scrotal sac, and the treatment is mainly the surgery and with a pre and post-operative care. So now coming to the MMDP. What is MMDP and what is WHO's essential package of care? The goal is that there has health facilities in every district with known patients must be able to provide treatment of acute attacks, because I have already said that it is very important to treat the acute attack as well as to prevent the acute attack. Second point is management of lymphedema. Management of lymphedema means it could be reduction of lymphedema, or maybe better to avoid the prevent acute attacks. And the third point is to management of surgery for hydrocele. And fourth point is treatment of LF infection. Treatment of LF infection means if there is any LF infection or microfilaria positives come in, they should also be treated. And the goal is 100% geographical coverage. 100% geographical coverage means that any patient or any area where there is a patient there, these services should be available. So it is not that geographically, but everywhere, wherever there are patients, there should be some facility providing these MMDP services, that is treatment of acute attack, management of lymphedema, management of surgery for hydrocele, and treatment of LF infection. Now, we have talked about the acute attacks, and said that promptly treated. What are the treatments? So since the etiology of the acute attack is antibiotics, or this is caused by antibiotics, the first line of treatment is antibiotics. As I said, could be streptococci or staphylococci. That coverage also should be there, but depends upon the country's antibiogram and the plan. Then there should be symptomatic management also, like analgesics, then anti-inflammatory medication, and if the patient has high fever, antipyretics, if there is vomiting, antiemetics. And supportive measures are the patient should be resting, the legs should be kept elevated, the hydration should be adequate, and can cool the affected area. And this person should not exercise during their acute adenolymphangitis, because they are already having the fever, the pain, and once they exercise, it will not benefit the person, but will increase the pain. Then management of entry lesions. That means that we usually in the acute adenolymphangitis, we have to look for the acute entry lesion, and that should be promptly treated. So that means that if there is fungal infection, antifungal cream should be applied. If there is a wound, either antiseptic or antibiotic ointment also should be applied. Now, moving on to the lymphedema management. This is also very important. And the lymphedema management, it's not a hospital treatment or the clinic treatment. These should be done in patients on a daily basis, and that could be helped by family or friends. There are 5 components. One is the hygiene practices. Second is the skin and wound care. Third part is the exercise. And the fourth is elevation. And fifth is the wearing of suitable shoes. So we'll see each one of them. For the hygiene practices, clean water at room temperature is needed. It should not be hot water, or we need not use the warm water also. It could be at room temperature. There should be a bucket to collect the water. There should be soap available, which is ordinary soap or the unscented soap. And there should be a towel or gauze to dry the surface. And there should be a cup, basin, chair for the patient to sit, and comfortable shoes. So in hygiene practices, the affected area should be washed actually twice daily, but at least once daily before going to bed, with soap and clean water at room temperature. So when the person is washing, they should start washing from below the knee. Usually lymphedema, filarial lymphedema, usually the edema is below the knee. So it should start from below the knee downwards. And they should wash thoroughly. But when you say that washing thoroughly, they should not be using any hard objects like brush or anything, because if they use the brush or any hard object, that will produce excoriation of the skin, and that will act as a entry lesion, and they may go in for a adenolymphangitis. So when they have skin folds, that should be, they wash carefully between the skin folds, and also between the toes, they should wash clearly, because we have told that those are the common sites for the entry lesions. After washing carefully, after washing very well, drying is also very important. They should dry carefully all areas with a clean towel or gauze. And the person has to wash both legs if it is unilateral, because the basic pathology is lymphocele dilatation. So even though the edema is there only in one limb, we don't know whether there is a lymphocele dilatation already happened in the other normal looking leg. So when it is bilateral, both legs should be washed. In a unilateral, wash the normal limb also, but they have to wash the affected leg first, and then the normal leg should also be washed. If bilateral, start with the leg having higher stage of swelling, and then followed by the other leg. And the nail also should be taken care of, because if the nail is not cut, or if there is a sharp nail, what happens is during sleep, patient may there may be injury happening with the neck on the affected limb, and which can predispose to a acute adenolymphangitis. And also, moreover, the nail infections, what is called as peronekia, if there is an infection in the nail, that is also an entry lesion which hastens an acute adenolymphangitis. And as we have already said, take care of the entry lesions, apply appropriate ointments and antifungal or antiseptic. So washing is very important, and equally important is the drying the areas, because what happens is usually in a patient with lymphedema, the toes will be thickened. So when the toes are thickened, there won't be any space in between. If the space in between the toes are not dried well, washed well and dried well, the moisture may remain there, and that will favor fungal infections. That fungal infections can lead on to recurrent adenolymphangitis.
You want the stains taken out of the seat? You guys want?
The next is the skin and wound care. This is because injury is a common entry lesion. Protect skin from injury by clothing or by using the footwear. Use washing as an opportunity, identify and address entry lesions and treat them properly. When there is a wound or a blister, do not open or cut blisters or damage the skin. Do not use too much of medicated cream, as this causes waste and attracts dirt. And when there is dirt, the person scratches, and that will be a excoriation and entry lesion. Just rub the cream into the skin. Do not completely remove the nail. That is mainly if there is a wound, that should be adequately cared, and the measures should be taken, and it should be the person has to get it healed as early as possible. But more important is not having any skin lesions. Exercise is also important to enhance the flow of limb, that is low intensity movements around joints in the affected area of lymphedema. So the first one is the up on the toes. The person should be standing on, supporting on a chair on a wall, and they have to raise on the toes and then come back. They can do it both legs together or one leg at a time. And this can be done 5 to 15 times. They should stand on the toes and then come back, then again stand on the toes. And it is always, the person should be reminded that they should be either holding onto a wall or a chair, because of the instability or imbalance between the legs, they may otherwise fall off. Then toe point is another exercise. That is when the person is sitting or lying down, they can raise the dorsiflex the leg and raise the toe, and then again get into the previous position. This also they can do about 5 to 15 times a day. And the third one is the circular movement at the ankle, what is called as the, they can do it clockwise, and as well as the anti-clockwise should be done. So there also they can do independently on each leg or together. So up on the toes, then toe point and circle exercise. These exercise they can do at any time when they are resting or making some doing some domiciliary course, or even when lying down. But the most important or the most beneficial time for the exercises when the person before getting up in the morning with the bed, because that is the time when the even with the grade 3 edema, the edema will be less. Maximally, the edema will be reduced in the morning time when they are getting up, before getting up from the bed. So that is the ideal time for exercise, but they can do it on all the other times also. Then elevation is also done to enhance the flow of lymph. So it can be performed during regular activities, work, leisure, or breastfeeding. And the leg should be elevated at the level of the hip, and always make sure that on the surface where the leg is elevated, there should not be hard subjects which may injure the leg. So they can use a pillow or a cushion and keep the legs elevated. And most importantly, every night when the person is sleeping, the person should elevate the legs, and this should be done by keeping a pillow underneath the mattress. Usually the practice is that the person will be keeping the pillow underneath the leg. Then what happens is during sleep, the person may be moving and the pillow gets off. So they will not get the desired effect. So both legs should be elevated and the pillow should be under the mattress. Raise the entire leg and not just the foot. And the fifth component of the lymphedema management is wearing comfortable footwear that protect the foot from injury and dirt. The why it is comfortable is that it should adapt to the volume and shape of the foot, because it should not be too tight or should not rub or pinch on the foot and cause blisters. And choose shoes that allow air to circulate. It should not be closed. So choose the many places, if they do shoes, it's not actually meant as the footwear. So the footwear that allow air to circulate around the foot, and we customize also, because some of the programs give the shoes made by the cobblers. So if it is available, if it is it could be done by the program, that would be good for the patients. Otherwise, sometimes they'll buy it, but it should be desirably be adapted to the, not desirably, it should be adapted to the volume and shape of the foot. So the 5 components of the lymphedema management is hygiene practices, skin and wound care, exercise, elevation, and wearing of suitable shoes. Then 2 points about the hydrocele, because the essential package of care means it is treatment of acute attack, management of lymphedema, management of hydrocele, and treatment of remaining infection. W. Bancroft infection, surgical correction is the management, and there should be a diligent pre-operative and post-operative care. And treatment of remaining infection means it is DEC 6 mg/kg plus albendazole, single dose, or DEC 6 mg/kg per day into 12 days. Usually, this is what is given in the aid memoir, and in some places, what they do is the national policy. It will be according to the national policy. So this I have already used. And in the GPELF, for the Global Program to Eliminate LF MMDP framework, for the program, there should be initially patient estimation, and the situation is analyzed and a plan is made, and there should be delivery of the essential package of care. And there should be looking for the quality and all that. And it is very clearly, even the program is over, there will be patients remaining. So ideally when delivering the essential package of care, it is important to integrate with the health services, because there will be lot many patients. They will not be able to travel distances, so they will not be able to go to the tertiary care hospital or a secondary care hospital, and that is also not needed. and it should be with the primary health system of the country. So even though there are studies and it has been known that the essential package of MMDP care is important in or beneficial, and the patient gets a lot of benefits, and also there is improvement in quality of life. But this MMDP has not taken up as well as the MDA program. So what are the things which prevents, or we don't know exactly what are the challenges, what are the things which prevent people to continue, what happens to the sustainability of this program. And there are certain points I would like to say, that is, what are the unknown or less known points on MMDP or essential package of care. The essential package of care or the MMDP services, when it is delivered, that reduces or applied physical, mental, economic, and social suffering. Physical means sometimes there may not be increase in the lymphedema. The lymphedema may remain or maybe improving, and there may not be any ulcers or things like that. So the stigma reduces and there will be mental enhancement. The acute adenolymphangitis will be reduced, and there will be economic and social sufferings also will be reduced. And it definitely reduces frequency and severity of ADL, and that is by lymphedema, and also prompt treatment of LF. And when the frequency and severity of ADL is reduced, it decreases progression of lymphedema. So, and in children, studies have shown that the MDA drug reverses early pathology. And even in studies that have shown that in stages 1, 2 to 3 lymphedema, there could be reduction or reversibility in lymphedema. So these benefits we should know, and we should tell the patients and the relatives and all that, so that they'll be coming forward and taking or doing the lymphedema management and all the other aspects of the essential package of care. So it decreases the lymphedema, decreases the ADL, decrease progression of lymphedema, and in some cases it could be reversible also. It may reverse some group of edema, and also it improves quality of life. And these patients, when they are trained for the lymphedema management and the essential package of care, they form self-help groups. Because after sometimes when they are doing it daily, regularly, they will understand the benefits. All these benefits they'll understand, and they'll try to help others who have not been initiated onto the program. And this, they form self-help groups. And what I have seen is the most important benefit of this self-help group is reduction in stigma. So we have a program where there is a lot of benefits for the person affected by lymphedema. But why it is not happening, why it is not being taken up? So the gaps should be, there is a question, why should it be done? Because the lymphedema is there, and what are the benefits that is going to happen to them? Because I remember that when I started working at Alappuzha and in any other hospital at that time, the lymphedema patients were the most neglected part of the lymphatic filariasis, because nobody knew what to do for the adenolymphangitis or the prevention of adenolymphangitis or the lymphedema. So they will be given antipyretics, anti-inflammatory drugs, and they may be in a corner of the ward and not being well taken care of. But we have a lot of things which we could do for the patients, which will be later taken up upon by the patients themselves. How should you do this? How long should be done? Who all should do this? And is it feasible? Will it not cause out-of-pocket expenses? Is there any benefits? So these are the deficiencies knowledge which prevents from trying to spread this essential package of care. So the important method or important strategy should be, to be effective, the MMDP must be integrated with the primary health system and should be integrated with other disease programs also. So in the community involvement, I'm just giving you some points alone, but we can develop the system and how to increase upon the community involvement. In MDA, we talked about creation of awareness. The main point here is that many people do not know what is the cause of the lymphedema, because they say that previously people used to say that if they walk through the hot sand, or it may be due to some sin, and there are a lot of beliefs like that. They didn't know the cause of it, how to prevent it, what is the treatment of lymphedema. So when the awareness is given, that improves access to and even utilization of lymphedema services provided through available facilities, because when there is program, there should be development of these facilities also. So when they know that if you go there and if you practice this, there will be reduction, they'll utilize the facilities more, especially when it is integrated into the primary health care. Awareness of patients about health facility providing MMDP services increase access, because they will say that if it is in a secondary hospital or other hospital, they'll say that if you go there, they will not give us anything. They'll give some tablets. That is all. There is no point in going there. But if there is a primary health center or in the clinic where if they know that where is the facility where they get the MMDP services or the management of lymphedema, they'll more often the patients will go, and then later on they'll acquire the knowledge and they'll continue to do it. And the reduction of stigma, there is a lot of, I can say that even in a place where I joined here, the stigma was huge, but now it is very much reduced. Stigma reduced, when there is a social acceptance and discrimination. So when they do the lymphedema management, the smell disappears, the appearance disappears, so they'll get accepted more, and others will also be knowing what is happening there. And these are barriers of health seeking behavior also. Awareness and knowledge reduces stigma. Learning about hygiene practices improves confidence and social interactions and reduces stigma. And as I have told, the patients who know the hygiene practices and know that that is beneficial for them, they'll try to help other people also. So that is only because they never knew about it, they were not knowing it, but there should be a thorough awareness creation among the community, among the patients and the family. So I would say the awareness of the training, the healthcare providers should know about what is EPC or essential package of care, what are its benefits. And importantly, it is a very simple procedure because the patients are doing it every day. Initial part is only to train the patients and then they'll take it up. Then the program staff, the patient, family, and friends. Always we make for a family members to stand with the patient when you initiate them into the lymphedema management and essential package of care, because that will help the family or the friends to help the patient, and there also the stigma is being reduced. Then community volunteers, patient care providers, and it could be at the health level, it could be a cascade of training, initially training of the trainers, primary healthcare physicians, secondary or tertiary care specialists, nurses, healthcare workers, and peers. So everybody coming in contact with or in the area endemic for lymphatic filariasis could be trained on these lymphedema management, and also given awareness regarding the disease, its complications, its suffering for the patients, and how to get rid of the suffering and get some benefits for the patients. So I think that we'll have some time where the community engagement will be same as in case of MDA. So looking forward to that. Thank you for the patient hearing.
Wonderful. Oops, it looks like my video is not starting. So that's too bad, but thank you so much, Professor Krishna Shastri. It was wonderful to hear from you and all the insights that you had to share around lymphedema management. And we have quite a few questions coming in the chat. So I'll pass it over to Caitlin and we can move on to the discussion portion of the session.
Wonderful. Thank you so much. And thank you so much, Professor Suma, for that really comprehensive presentation on taking us through the importance of the essential package of care and the way that we can engage the community. We have lots of really great questions in the chat. I might start with one from Dr. Doris Njomo, who asks if you can share your experiences about the sustainability of self-help groups formed by your patients, and particularly what does sustainability look like beyond the project or program intervention? think lots of programs have this question, especially as they're approaching validation.
Yes, my experience is that we had one study where there is a 5-arm study, and the patients were initiated on the hygiene practices, and we were trying on whether it is antibiotics, anti-inflammatory, which drug is beneficial. And at the end of study, we found that all we're looking for the reduction in adenolymphangitis. In all the 5 groups, there was reduction in the adenolymphangitis. So all the 5 groups were given intensive training on the hygiene practices, and that was the one which helped the person to reduce the adenolymphangitis and making them better. So these patients were trained on them. And this study was for about 3 years. Then patients have gone back to their villages, and we did in between contact the patients, and we contacted the patient after 2 years. After 2 years, we wanted contacted, and we wanted to find out whether they are continuing to do the hygiene practices, whether they are doing like they remember the instructions given, what are the benefits for them, and if it is helping them, or what all they were doing. Actually, I have the patient excerpts from that study, and if time allows, I can show you that. So there, what happens is that in 98% of the patients had benefits. 95% of them were using, and out of which 98% had reduction in the frequency as well as the severity of the acute attacks, and they had definite benefit. They never had to spend extra from their pockets, and so they were happy about it. Can you tell me? Can you give me 2 minutes?
Go ahead.
So this is a comment from a study subject. After treatment here for the last 4 years, I did not have a filarial fever. They used the local language there. I'm able to carry on with my work. I have no deaths now. Before coming here, whenever I had fever, I had to get death for the treatment. Now I am able to have my oil bath every day without any fear of getting the fever. I am also relieved that now there is a place for me to rush to if I get a fever. That is what I said. Awareness of availability of the services is also important. Another patient, I get fever whenever I get injured, maybe even thorn prick in the swollen limbs. Similarly, I get the fever when I have valangadi, that is the fungal infection between the toes during the rains, or between my fingers while washing clothes or utensils. I do not have fever now because I am careful not to injure my limbs. So it is with great care that I even cut nails, avoid any injury. This shows that they are aware of the cause for the precipitating, or what all could be the entry lesions, and when they are going to get adenolymphangitis. So this has happened after repeated instruction to them what all things they should do. So another patient said, I helped a person by washing his legs when I found that he had huge swelling on both legs with ulcers. There were maggots in the ulcers. I washed his legs myself using soap and water and applied the ointment given from here in all the folds of the swelling. The relief of his pain and itching after I did was remarkable. The next day again, he came asking for some more ointment. This is helping others and also forming the self-help groups. Because what happens is after about 1 month or 2 months, or maybe 3 months, they'll know the benefit. Because in our doxycycline study, all the patients used to come and say, either group was saying that there is a reduction in the heaviness of the leg, and we feel happy, we will feel comfortable, and there is no adenolymphangitis happening to them. Okay, thank you. So sustainability, that we have to instruct them very well, and we have to initially see that they are doing it correctly. What we do is that initial weeks, they'll ask them to frequently to the hospital. After that, the healthcare workers or the ASHA workers or the community workers go to their homes and reinforce it. So after, because there may not be any result within 1 week or 1 month or so, but because when you have to tell them to continue it, and that will, after some time, the patient will know it is beneficial for them and they'll continue it and they will spread the news also. So that way we can have a sustainability of the program.
Excellent. And just related to the acute attacks, we have a question here about if it ever leads to sepsis or any other kinds of complications.
Excuse me, can you come again?
Sure. Do the ADL episodes ever lead to sepsis or other complications for the person who's experiencing them?
ADL attacks, that is, I was telling that if the person has like comorbidities, if it is a simple organism, it may subside in 5 to 7 days. But if it is not, if it is a virulent organism and to an immunocompromised person, that can produce sepsis, because we had patients lost because of the severe infection, because that produces the sepsis. But usually that happens is when we don't recognize that as acute adenolymphangitis and the treatment is not started early. So any patient, when a lymphedema patients with comes to the hospital with a fever, what we do, or what everybody does, is that we keep our hand on both legs. There will be slight increase, even slight increase in temperature on the affected leg shows that the person is going in for an adenolymphangitis, because initially there may not be all the florid manifestation. So immediately start antibiotic, because this is a bacterial infection. So they need antibiotics. If that is not given initially itself, that can become going for other complications like any infection, septicemia, multi-organ dysfunction, or even death. Okay, thank you.
Excellent. Yes, that speaks to another question that somebody had about antibiotics, and if there are any alternatives to using antibiotics if people have acute attacks. And this also speaks to some of the questions that people have around access to these materials, be it antibiotics or soap. How can we assure that people have access to these materials?
Yeah, antibiotics actually during the field work, maybe the healthcare workers can identify that the person is having a adenolymphangitis, and they have to be sent to the primary healthcare for antibiotic treatment. So if it is a minor infection or it's not very high and all that, as I said, usually with streptococcal and staphylococcal, we start with penicillin group of drugs, the amoxicillin, and depending upon the severity of the infection, we may have to resort to other also. So whenever there is a high fever and within 1-2 days it is not subsiding, the patient will require treatment from the hospital also, because we have to watch and observe and see how that is progressing or regressing. If it is regressing, it is okay, but it's progressing, you will have to change the antibiotics, or we have to add more. So that should be done at the hospital level, even primary healthcare or the secondary healthcare. Then about the other materials, actually, some countries, the people have all this bucket, mug, and all these things at home where they use it for their own this thing, and soap also. But otherwise, in many places, the program used to supply this, because it is not very costly, I think, because it is bucket and mug and basin, you need not give them always. What you have to give them, or recurrently or frequently, is the soap and the towel for drying. So that is more important than the other, because one bucket and they can use for many days or many weeks. So the other things have to be replenished. So the program, we'll have to find out some source in the program itself to give the kits for these patients.
And I know this is a validation program, and so the LF program in some locations will start to scale down as people reach validation. What kinds of suggestions do you have for sustainability of these programs well into the future, and making sure that there continues to be access?
I will say that the first and foremost is awareness creation, knowledge transmission, because Many people don't know whether it is effective. There are doubts whether these simple things will be effective for a lymphedema like this. And many people know what is the importance of acute adenolymphangitis and why should you treat that, or because it is just like any other infection. The point that the recurrent acute adenolymphangitis is definitely going to improve enhance the lymphedema and make the patient suffer more. So we have to, that cycle should be broken. So that thing also be known by everybody. And another thing is that acute adenolymphangitis, I have heard people saying that it's not due to bacterial infection. It is like any other inflammation. We have the very sad story that one of the doctors treated the acute adenolymphangitis. He said that it is not in the early stages, it's not infection, it's only an inflammation. But as I said, it rapidly progressed to septicemia and the person succumbed to the disease. So such sorry things also have happened. So the awareness creation is important. Also, like the cause and like the what is which is needed to be done, the patient should be trained well on doing the lymphedema management, the washing, the drying, then putting the ointment between the toes and also in the other wounds and all that. They should be demonstrated, that should be known well, and their family should be there and they should also be helping them. So if that process can happen, I think it could be sustainable because the beneficiaries are always the person affected and the family. So they'll continue to do it.
Excellent. There's great questions in the chat. I'll also invite anybody who has a question they'd like to ask to raise their hand and come off mute. Until then, we have some questions.
There's a question with that. Comfortable shoes, can we recommend customized MCR footwear? We can recommend customized footwear, but the problem here is the lymphedema patients are usually in the low socioeconomic strata. They may not be able to buy it or make them by themselves, but there are people who could be affordable. This can be done. And there are places where these shoes are being, even in India, about with the leprosy program and LF program integrated, there are the footwears are made and that is given to the patients.
Well, there's another question that just came in. Beyond support groups, do we have any examples of clinical mental health interventions that can be integrated into LF treatment? You spoke about stigma and people feeling rejected. So what other options are there for mental health support?
Yes, we had and we see among these patients other mental health issues like depression, anxiety, sometimes suicidal tendencies. And in the early days, most of the patients will come and tell us that please get the leg amputated because of the recurrent infection and all that. They may not be able to bear it and they ask for the amputation. And those people, many of them will have a suicidal tendencies also. So there, the counseling and getting them needed advice and now putting into the program and do it and making them move around with other peers. Peer support is very, very important. Then the patients, when they get better, we can get some vocational training and to give some jobs for the patients, like small jobs which they can do by sitting or in the groups and all that. They'll get engaged in it, and there are a reduction in the mental health problems. And there are in our primary healthcare centers, there is a program separate as the mental health care the district mental health care program. So that's because patients may not like to go to a psychiatry department. It should be the mental health system, and when it is there, the clinic is there, they'll like to go there. Then that system also can be developed.
Wonderful. Well, thank you so much. I think we're coming to the top of the hour.
Yes.
Thank you to all the questions, and I'll pass it back over.
Thank you so much, Caitlin and Professor Krishna Shastri. It was so wonderful to hear from you and hear your perspectives and just the power of involving community and supporting individuals who are impacted by lymphatic filariasis. So we are at our hour mark, and so thank you all for joining us today. It's so great to have so many people from around the world to be able to learn together. So I've posted a poll just to gain some feedback on the session today. And you may have also seen that I-Cords has put out a call for steering committee members, which closes at the end of the week. So there's more information if you follow that link that I just posted in the chat. So I won't keep you any further. Thank you everyone for joining, and I hope you have a good rest of your day.